Sarah's liver was failing. And if she could get on a transplant list, she might go right to the top. Sarah lived with her mother and her siblings in Waukegan, a suburb of Chicago. And while her mother worked, the family was uninsured. And Sarah was denied an appointment at one of Chicago's leading transplant centers. Her mother later recalled, "They told us we had to raise $500,000, but we couldn't even raise $10,000. Sarah died. She was 25. We all die. But tens of thousands of Americans die too soon. And the killer is not random. This killer strikes particular people in particular American neighborhoods. And unlike cancer and heart disease, this killer cannot be treated with medications or surgery. This is bigger than the war on cancer. This killer is inequality. Inequality is responsible for so many early deaths in America that we need to treat inequality itself as if it were a disease or an epidemic like cholera or polio and eradicate it. It calls into question who we are as a nation and a people. And it sounds like it might be abstract or amorphous, but actually the solutions to this problem are very specific and concrete. And I learned how inequality killed during my 40 years taking care of poor patients from some of Chicago's most neglected neighborhoods. And from the vantage point of my examination room on the west side of Chicago, I got to see who gets to live and die in America. For almost 30 years, I worked exclusively at hospitals that only serve the poor. African Americans, Latinos, immigrants. And because of the poverty of the patients, these institutions were always under financial stress. And treatments and examinations and therapies and x-rays that were available at other institutions in the white neighborhoods and the wealthy neighborhoods of town were out of reach for me and my patients. Once the chief medical officer of Cook County Hospital, where I spent almost 20 years, Chicago's public hospital, said to me, "David, the wait list for the eye clinic at County is so long that you can go blind waiting. And yet, at the private hospital across the street, you can see the eye doctor today if you have the right insurance card." For all those years, not one of my patients who needed a life-saving organ transplant ever received one, even though their family members were willing to donate organs. And like Sarah, I watched them die. And yet many of the organs that went to nourish the lives of transplant recipients, often middle class and white people in other institutions, came from the black and brown patients in our ICUs. In the city of Chicago, and it's true across the country, 30% of the organs came from the uninsured. Our patients gave, but they never got. But it's more than just the frank inequity in healthcare delivery that caused premature death. There was something about the neighborhoods themselves where our patients lived and the exposure to the toxic stress of poverty, of poor housing, of low-wage jobs, of policing and other things that shortened lifespans. In addition to being a doctor, I'm a social epidemiologist. And an epidemiologist compares disease rates in one community versus another. And there's one way to sum up how inequality kills, one number that we can use, and that number is life expectancy. This is a map of the L tracks in Chicago, and it's going to show you that where you live dictates when you die. And if you live in Chicago's Loop, a neighborhood of concentrated affluence, mostly white people, you live on average to the age of 85. And if the Loop were a country, it'd be ranked first in the world in life expectancy. Think Japan. But go 7 stops down the blue line, 3 stops from where I practice medicine, and you land in the neighborhood of Garfield Park, and life expectancy plummets to under 69. Think Bangladesh. And Garfield Park is a neighborhood of concentrated disadvantage, mostly African American. How could this be? You ask yourself, when was the last time in America that life expectancy was under 69? And you'd have to go all the way back to 1950. 7 stops, 7 decades. So you may be thinking, well, this is just Chicago. This is actually national problem, and it's getting worse. Cross the 405 in LA and lose 16 years of life expectancy. Go from white Fairfax County, Virginia, to all white and poor McCollum County, West Virginia, and lose 20 years of life expectancy. And it's international. Go from the south of England to the north of England, you lose 8 years. Go from the wealthy districts of Shanghai to the poor districts, and you lose 14 years. But it's particularly growing in the United States. Here's a fact. A 16-year-old African-American teenager, young man, who lives in a neighborhood like Garfield Park has a little more than a 50% chance of living to the age of 65. Why is this? I've asked this many times in many audiences, and the answer usually is, well, it's gun violence. And certainly gun violence in Chicago is a problem. But more than half the early deaths in a neighborhood like Garfield Park are from heart disease and cancer, diseases for which we have prevention, early detection, treatment, and even cure. So it's a form of violence, but it's not interpersonal violence that's causing this. It's something that's called structural violence. And it's structural violence because the conditions that cause ill health are structured and designed into our laws, our policies, our procedures, and norms that govern day-to-day life in neighborhoods. And it's violent because people die early as a result. I need to pause here for a second. As a white man and as a doctor who's practiced in these neighborhoods for all these years, it's only recently that I have felt comfortable naming racism as a key driver for premature mortality, separate from poverty itself. And I want to explain why. There are many poor white people in Chicago, but there's not one poor white neighborhood. So a young white girl growing up in a neighborhood has available to her all the things in that neighborhood, the parks, the schools, the grocery stores, the health care, and has the potential to get out. If you go look across the United States, there are 171 cities, and not in one city is there a white neighborhood that's more economically disadvantaged than any black neighborhood in America. And this means premature deaths are burdened on top of the black population. In the United States, 200 black people die every day just because they don't have the life and health experience of white people. Many years ago, my friend Steve Whitman, an epidemiologist in Chicago, added up all the excess white deaths in Chicago, and it became the front page of the Sun-Times. It says 3,200 excess black deaths in Chicago, just because black people in Chicago did not have the same health and life outcomes as white people. Does that number look familiar to anyone? Some major thing in American history? This is the number of people that died in 9/11. But I just want to say this is not exclusively about racism. Poverty itself, no matter where it is, kills. And over the past 30 years, we've seen that 20% of the highest wage earners in the United States, their life expectancy shoot up. And the lowest 20% of wage earners in the United States, white, black, and others, their life expectancy has dropped, something we don't see in other countries. And for the past 2 years, because of this fact, the overall life expectancy in the United States has dropped, and we're the only developed country in the world that's seen a life expectancy drop. So those are grim statistics, but I'm here to tell you inequality is not inevitable, and it's not immutable. We can do something about it. In addition to being a doctor and a social epidemiologist, I'm a human rights activist. And I believe that the right to health and healthcare is a human right that should be available to everyone, regardless of their income or their situation. And all we have to do to get there is believe that we can be agents of change. So what does change look like? How do we change this? So one, we need to change the narrative. So we need to change the narrative of what's going on in our neighborhood from something, a factor of personal responsibility to social responsibility. We have to figure out how do we partner better with leaders in these neighborhoods who know what's going on the ground and can help lead the institutions to solutions. But most importantly, we've got to measure the impact of this, because these are inequities, they're unjust, and there's an urgency to act. So we need to act. So when Sarah died, her congregation carried caskets from their storefront church 7 miles to the front doors of Northwestern and held a funeral and a hunger strike. And the attention that got changed the narrative about transplant in Chicago. And the community got together with the transplant institutions, and we were able to actually get people insurance. And since then, 130 people made it to transplant lists. 70 have gotten transplants. And most of the organs, 75%, came from community members and family members. And as a result, donations of organs are way up in the area because it's a fair system. And when we showed this map around the city, people said, that's wrong, that life expectancy is so low. What can we do? And the hospitals and the community have gotten together and created a collaborative called West Side United with the aim to reduce the life expectancy gap in Chicago by 50% by 2030. And that's the usual map you see of the city. This is the map the community leaders on the West Side made of their beautiful community. Green, lots of assets, changing the map of the city in these neighborhoods from hopelessness to hope, from risk to opportunity. And solving the problem of inequality is quite concrete if we focus on health and healthcare, neighborhood structure, jobs that pay good wages, and education. These are not obscure things to do. And what we asked the community leaders to say, what would the headlines look like in the future? And this is one of the headlines that they came up with when we're successful. West Side life expectancy matches that of the Loop, or this one, from violence to victory, changing the West Side story. So we are not stuck in this place. There are no limits to what we can do. Frankly, as a doctor who's done this for many years, I'm sick and tired of watching my patients, who are also sick and tired, from dying and getting sick from poverty and racism. We have an American dream, but not everyone gets to live the American dream, life, liberty, and the pursuit of happiness. We have the opportunity to make a difference if we all join in together, because we can't do this one disease, one neighborhood, one city at a time. We can't settle for less. Thank you.